So I've really seen quite impressive responses with Eribulin. I think that the therapy is highly efficacious and is really useful in a patient population that is resistant to chemotherapy. The drug is approved after 2 lines of chemotherapy in the metastatic setting, and we do see the law of diminishing returns when it comes to responses that we expect in patients that have had prior treatment. Yet that being said, patients do respond to Eribulin quite well, and it is associated with the survival benefit. I have found the drug to be pretty well tolerated. Neuropathy does become an issue and is generally managed well. I don't think that it's been an issue for me in terms of having to take anyone off study based on a neuropathy. Other issues include neutropenia, which can be handled with dose delays and dose reductions and the use of growth factor support. So if a patient is neutropenic, the package insert guidelines indicate that if they have an absolute neutrophil count of less than 1,000 on day 8, that dose should be delayed and for up to a week. And then if there is no recovery after 2 weeks, that is an indication for dose reduction. There's also the option of omitting the day 8 dose. I have in my practice been able to pretty regularly get patients on a schedule that they can tolerate. The first or second cycle is the time that we're trying to identify the dose that is the best tolerated for the patient and the schedule. So Eribulin is associated with other adverse effects beyond the ones that we've already discussed, including neutropenia and neuropathy being the major ones. There is some asthenia and fatigue. There can be issues, gastrointestinal side effects, but I think that that's pretty common with a lot of chemotherapy agents. The alopecia rate reported in the trial was about 45%, which is what I see in my practice. But I do find that as patients are treated with multiple lines of chemotherapy, the alopecia issue becomes less important to them, especially in the context of a survival benefit. I find that many patients don't seem to have that as an issue, although of course everyone is an individual and those discussions should be had on an individual basis. So in summary, I would say that we have the potential to have a lot of new therapies on the horizon for triple-negative breast cancer. It's an exciting time for patients who have traditionally had a poor prognosis, and this is an area of high unmet need. I think many patients that have triple-negative breast cancer and have larger tumors or lymph node involvement are increasingly being treated in the neoadjuvant setting. We have studies that are looking at what to do with patients that have residual disease and don't achieve a pathologic complete response, as we know those patients are at higher risk for recurrence. There are many drugs that are on the horizon for triple-negative breast cancer patients, including checkpoint inhibitors, vaccine studies in the adjuvant setting, and for patients that harbor a BRCA mutation, the PARP inhibitor olaparib is now an exciting new therapy for patients. In terms of Eribulin in the treatment of metastatic triple-negative breast cancer, I do think that this is a highly efficacious and well-tolerated treatment with a survival benefit, which is a hard thing to achieve, as demonstrated by multiple other studies that have not been able to identify a survival benefit. The treatment is very well tolerated and is highly efficacious.